as we have already discussed that based on laparoscopy, the pelvic inflammatory disease is classified into 3 types. Inflammatory disease is classified. Now guys, in this lecture, I will be mainly concentrating on severe pelvic inflammatory disease. See, these are the CDC regimens. Okay, you should never change the CDC regimens, Center for Disease Control. See, for the treatment of severe pelvic inflammatory disease, we have mainly 3 regimens are there. What are they? You have to give 3rd generation cephalosporins. One is cefoxitin 2 gram IV every 6 hours, plus you should add doxycycline 100 milligram BD for 14 days. Means for 14 days what you should give? You should give this 3rd generation cephalosporin cefoxitin 2 gram IV every 6 hours. For 14 days, every 6 hours you have to give. Plus you have to add this doxycycline 100 milligrams BD. Why we are using this doxycycline, guys? Guys, remember, wherever there is gonorrhea, there will be chlamydia also. Doxycycline is the drug of choice for chlamydia. And 3rd generation cephalosporin cefoxitin will take care about the gonorrhea. Okay, so if there is no availability of the cefoxitin, you can also use cefotitan. Okay, also 3rd generation cephalosporin. Cefotitan 2 gram IV every 12 hours, and the same doxycycline 100 milligram BID for 14 days. Okay, either you can use cefoxitin or cefotitan. If you are using cefoxitin, give it every 6 hours. If you are using cefotitan, you can use it every 12 hours. And one more regimen you can use here is the Clindamycin cream. Clindamycin 900 milligram IV should be given every 8 hours. Okay, so plus along with that you have to use a gentamicin loading dose. IV or IM you can use 2 milligrams per kg, followed by maintenance dose of 1.5 milligram per kg. On one hand you have to use clindamycin. Along with that you also have to use gentamicin IV or IM 2 milligram per kg, followed by a maintenance dose of 1.5 milligram per kg every 8 hours. Okay, so mainly I just want you to remember the management of a pelvic inflammatory disease in a severe condition, severe pelvic inflammatory disease. See, there is also an alternative parenteral regimen for severe PID. Okay, other than giving 3rd generation cephalosporin and doxycycline or clindamycin along with the gentamicin, there is also one more alternative regimen where you can use ampicillin or sulbactam 3 grams IV every 6 hours, plus doxycycline 100 milligram orally or IV every 12 hours. See, doxycycline is common. Here we are taking penicillins. Okay, ampicillin or sulbactam 3 grams IV every 6 hours along with the doxycycline. So these are the regimens for the severe pelvic inflammatory disease. Now let's see the complications of the pelvic inflammatory disease. Okay, a female is having the pelvic inflammatory disease. What are the complications she will be having? The pelvic inflammatory disease. What are the as there is inflammation going on her uterus, fallopian tubes, tubo-ovarian abscess. Okay, even inflammation in the peritoneal cavity, there will be infertility. Okay, so she cannot be pregnant. Why? Because the tubes are blocked. Even the uterus, there is too much amount of inflammation is going. She cannot be pregnant. Now, the ectopic pregnancy can occur. Guys, the tubes are inflamed. Okay, you have treated this. But remember, whenever there is inflammation in the tubes, there is formation of the scar tissue. You have treated the pelvic inflammatory disease. Next, she conceived after 6 months. As there is a scar tissue in her fallopian tubes, this zygote may be implanted onto the scar tissue. So that can lead to ectopic pregnancy, tubal ectopic. So infertility is a complication, ectopic pregnancy is a complication because of too much amount of inflammation. She can have chronic pelvic pain, and even this inflammation can ascend upward and cause inflammation around the liver, that is perihepatitis, leading to 𝐒𝐻-𝐫𝐞 syndrome. Okay, now after this, now let's see some important points regarding genital tuberculosis. Guys, do you know the major difference between a pelvic inflammatory disease because of a gonorrhea and chlamydia and because of a genital tuberculosis? See, chlamydia, gonorrhea, mycoplasma, all of them are causing pelvic inflammatory disease because of ascending infection. But this genital tuberculosis is mainly because of the hematogenous spread. Okay, see, I got the pulmonary TB, for example. Or for example, there is a female who have the pulmonary TB. From the primary site, means from her lungs, the tubercular bacilli, they are spreading to the uterus, and there they are causing the pelvic inflammatory disease. So genital tuberculosis is always a secondary infection spread via hematogenous route, and the primary infection sites are lungs followed by lymph nodes. First lungs are affected, the second most common site is lymph nodes. From there, it can spread to any organ system in the body. If they are spreading to the genitals, that will be causing pelvic inflammatory disease. Now, most common site of genital tuberculosis is, see, TB likes to have tubes. Okay, TB likes to affect tubes. So the fallopian tubes are most commonly affected bilaterally. If the person is having genital tuberculosis, there is bilateral endosalpingitis, and even in the tubes, ampulla is the most common part affected. And from the fallopian tubes, the infection can spread into the uterus, which is just site. So second most common site of the genital tuberculosis is uterus. Okay, now most common age group affected is reproductive age women. Okay, most common symptom is very important, infertility. If the female is having genital tuberculosis, the first complaint that she is going to give to you is infertility. Okay, never get this genital tuberculosis. Why? Because it can make you sterile. Okay, why? Because it causes very much problems with the fertility. Now, hysterosalpingography. If you do hysterosalpingography, see, usually because of this genital TB, the tubes are affected. Most of the times the tubes will be blocked. For example, you have done the hysterosalpingography. Tubes may be patent. For example, tubes are open, but there may be a functional loss. Okay, though the tubes are opened, functionally the tubal function is lost. For example, tubes have to have a peristaltic movement in order to move the product of conceptus. The embryo should be moved from the fallopian tubes into the uterine cavity. Because of the peristaltic movements, that movements are lost, the functions are lost. Okay, now most common site affected in the uterus, it is cornua. Okay, see, the most common cause of bilateral cornual block is genital tuberculosis. What does I mean by? For example, if this is the uterus, these are the fallopian tubes, this is the point known as the cornua. Because of the genital tuberculosis, these cornual regions will undergo blockage, spasms. So that can also cause okay, now here in these x-rays you can see that upon performing hysterosalpingography, see here the radio-opaque dye was put into the uterus, but see, this radio-opaque dye was just localized to the uterus. Why? Because there is a block over here, so that you cannot visualize the fallopian tubes. The fallopian tubes are not visualized. Why? Because there is a block, bilateral cornual block. See, even here, see, the total radio-opaque dye was just limited to the uterus. See, here you can see at least a small fallopian tube, but on this side there is a complete block. So these are some important points regarding genital tuberculosis. Now please see, this genital tuberculosis mainly affect fallopian tubes. If a uterus is affected, then we are calling it as a uterine TB. See, it's one and the same. It's a genital tuberculosis. Mainly tubes are affected, and from the tubes the infection can spread to the uterus. If it is spreading to the uterus, please concentrate, that will cause Asherman syndrome. This genital tuberculosis will cause lots and lots of inflammation in the uterus. So at the end of the day, this inflammation will cause intrauterine adhesions. You can see here there is lots and lots of intrauterine adhesions or intrauterine synechia. So these intrauterine adhesions or intrauterine synechia is known as Asherman syndrome. See, this genital tuberculosis will cause Asherman syndrome, there is no doubt. But if someone asks you, what is the most common cause of Asherman syndrome? The most common cause of Asherman syndrome is vigorous dilation and curettage. Okay, abortion. Okay, there is a too much amount of vigorous dilation and curettage. Okay, excessive scraping that can cause inflammatory changes in the uterus and that can lead to intrauterine adhesions. Now, what are the clinical features, guys? If the female is having this uterine TB, Asherman syndrome, she will be having amenorrhea or hypomenorrhea. Why? Because all that endometrium is lost. There is a too much amount of intrauterine adhesions. As she is not having proper amount of endometrium, she can hypomenstruate or she cannot menstruate at all. That is amenorrhea. Now, what's the investigation of choice? The investigation of choice is just directly look into the uterus. Okay, put a camera into the uterus and directly look. So this is hysteroscopy. So the investigation of choice for Asherman syndrome is hysteroscopy. Now, hysterosalpingography. If you have performed hysterosalpingography, usually hysterosalpingography is contraindicated. But unknowingly, if you perform hysterosalpingography, because of these adhesions, because of this intrauterine adhesions, that hysterosalpingographic studies will give you a honeycomb-like appearance of the uterus. And what is the treatment of choice, guys? The treatment of choice is you have to remove all these adhesions. Hysteroscopic adhesiolysis is done. Along with that, you have to put a intrauterine device to prevent the further intrauterine adhesion formation, and also as there is no endometrium, you have to make the endometrium to proliferate again. So you have to give cyclical estrogen and progesterone. So what is the treatment, guys? You have to do the hysteroscopic adhesiolysis followed by keeping an intrauterine device. Along with that, you have to give estrogen and progesterone therapy for this female. Now, if you have done hysterosalpingography for the genital tuberculosis, we have already seen, see, I have already said, hysterosalpingography is contraindicated in genital tuberculosis. But if you have performed it unknowingly, these kind of findings will be seen. Bilateral cornwall block, I have already said. See, if someone asks you what is the most common physiological cause of bilateral cornwall block, it's a spasm, physiological spasm during hysterosalpingography. See, while performing hysterosalpingography, due to irritation of the dye, the cornwall regions, they can undergo spasm. That is something physiological. But if someone asks you what is the most common pathological cause of bilateral cornwall block, then it is genital tuberculosis. So you can see bilateral cornwall block on hysterosalpingography. You can see honeycomb appearance of the uterus. Genital tuberculosis, tubes are mainly affected. So you can see hydrosalpings of the tubes can be seen. And even these tubes can have a beaded appearance. The beaded appearance of the fallopian tubes can be seen, and tobacco pouch appearance of the fallopian tubes is also seen in genital tuberculosis. Now, so how you have to diagnose that the female is having genital tuberculosis and how you have to treat it? See, diagnosis is done by endometrial biopsy. You have taken some endometrium and you have to send it for the PCR, and followed by you can also do a microscopy and culture. See, if you are doing PCR, microscopy and culture, you can definitely find out that the causative organism is tuberculosis bacilli. Okay, so that's how we are going to diagnose the condition and how we are going to treat this condition. See, treatment is anti-tubercular drugs. So for four drugs like 𝐻𝐴𝐺, isoniazid, rifampicin, pyrazinamide and ethambutol should be given for 2 months, and the other 2 drugs should be given for 4 months. Okay, the 4 drugs should be given for the first 2 months and the 2 drugs should be given for the 4 months. So this is the treatment. Guys, important point, remember, even after treatment, 50% of the females will have ectopic pregnancy. Okay, 20 to 30% of them will abort. and only 2% will have the live birth. See how bad this condition is. Okay, 50% of them are having ectopic pregnancy. And if they ask you, see, percentage of genital TB patients who are infertile, 70%. So never ever get the genital tuberculosis. Why? Because it can make you sterile. Okay guys, I hope the lecture is helpful. Thank you, and let's meet with the new lecture.